session, sir. So, so you can start the session, sir.
Okay. Good afternoon, all. At the outset, I'd like to thank ISCCM National for giving us this opportunity. I'm Dr. Bala Subrahmanyam. I'm a senior consultant at Citizens Hospital. Coming to today's topic, setting up of transducers or monitors and various hemodynamic devices, which is very basic and must known, and you also need to know about the nuances about and troubleshooting about these various hemodynamic devices. Without wasting much time, I like to call upon Dr. Sasidhar, who is a young and energetic consultant and very well known with hemodynamic monitoring. It's one of his core topics. Okay, he's a consultant critical care specialist at Citizens Hospital. Over to you, Dr. Sasidhar.
Thank you, Bala sir. Good afternoon, everyone. So today I'm going to talk about setting up hemodynamic monitoring in an ICU. So these are the topics I'm going to discuss today. One is the components and general principles of pressure monitoring system, arterial waveform, blood pressure and hemodynamic shock, CVP measurement, pulmonary artery catheter, and cardiac output monitoring. Coming to the components of pressure transducing system, see, any pressure transducing system has a few components such as intravascular catheters, connecting tubings or pressure monitoring tubings, pressure transducer, continuous flush devices, amplifier with electronic filters, monitor with microprocessors. Coming to the intravascular catheters, there are various types of intravascular catheters which we use for monitoring hemodynamic parameters in a patient in ICU. For arterial waveform monitoring or invasive arterial blood pressure monitoring, the most common sites preferred are your radial artery, femoral artery. In some rare circumstances, we can also use dorsalis pedis. See, the introduction of vascular catheters is done broadly by two techniques. One is your catheter over the needle technique, which you most commonly use in your radial artery, especially the switch cannulars which we use to cannulate the radial artery. And the second procedure is the Seldingen technique. Seldingen technique is the technique where we put a guide wire first and put a catheter over that. Most commonly, we use Seldingen technique for the femoral artery cannulation, CVP cannulation, and even pulmonary artery cannulation. So these are the gross techniques by which we put an intravascular catheter. And obviously, the utilization of ultrasound for putting these intravascular catheters will definitely reduce the complications and increase the success rate. Coming to the connecting tubes, the pressure monitoring tubing system, which connects the intravascular catheter to the transducer, is not just any tube. It's different compared to your IV tubings or your blood transfusion tubings. These pressure monitoring tubings have less compliance and they absorb less amount of energy when a waveform gets transmitted through it. Coming to the transducers, this pressure transducer is the heart of the pressure, any pressure transducing system or pressure monitoring system. It converts the mechanical energy of the waveform that reaches it into an electrical signal. And we also have a continuous flush device, that is your pressure bag with a normal saline collected, which continuously flushes the system at a rate of 1 to 3 ml per hour. This flushing keeps the catheters and tubings open, prevents clotting, and especially prevents the backflow of blood when you are monitoring the arterial pressures. And you have the electronics with amplifiers in the monitors and microprocessors, which converts this electrical signal coming from transducer into a waveform and into a number. This is an overall flow diagram. So from a cannula, maybe arterial or venous or a PA catheter, there's a coupling system that is your pressure monitoring tubings that will connect this cannula to a pressure transducer, where the pressure transducer converts this mechanical wave into an electrical signal, and the signal is amplified in your monitor and is displayed as a number and as a waveform. Coming to the pressure transducer, this is the basic principle by which a pressure transducer works. It's called Wheatstone bridge principle. See, all you have in a pressure transducer is a silicone membrane that has resistors on each 4 sides. When this catheter is distended by a pressure waveform or distorted by a pressure waveform, it generates an electrical signal that is carried to the monitor by a cable. So when you see the diagram here of a pressure transducer, it has 3 ports. One port is connected to the patient with a fluid-filled tubing. The other one is connected to the continuous flush system. It has a cable which sends the electrical signal to the monitor, and an opening where we connect a syringe and we can take a sample or flush the entire system. And we have a flush valve. Flush valve can be a full type or a squeeze type based on different pressure transducers. So essentially, this pressure transducer converts whatever the arterial waveform or CVP waveform that gets transmitted through this fluid-filled tube here. That waveform is transmitted through the pressure transducer, where this mechanical energy is converted to electrical energy based on Wheatstone bridge principle, and this signal is carried to the monitor, where the monitor does the rest of the thing. It calculates the values, it calculates the waveform, and it shows on the monitor. So what are the steps of transducing? Obviously, first we need to secure a vascular access. We need to set up a continuous flush system with a pressure bag. So how much pressure is needed? So when we connect a pressure bag to continuous flush system, the normal indicated pressure is around 300 millimeters of mercury. It should always be above systolic pressure. Ideally speaking, it should be around 300 millimeters of mercury. The priming of tubes. All the pressure monitoring tubing system should be primed with saline, and we need to be careful to avoid any air bubbles in the system. And the transducer is placed at a level of plebostatic axis or plebostatic plane. In the next slide, I will be explaining to you what the plebostatic plane is. We need to zero the transducer, and then we will optimize the waveform on the monitor. Coming to the plebostatic axis, any pressures in our body need to have a reference value, a reference to the heart. So when we place a transducer by the patient's bedside, we need to place it at the level of plebostatic axis. So how do you determine the point or reference point? The right atrium of the patient's heart is considered as a reference value. How can you locate right atrium superficially? Fourth intercostal space in the mid-axillary line is considered as a plebostatic point, and the horizontal axis that is passing through this plane is considered as a plebostatic plane. All your transducers, especially the stopcock of your transducer, should be at the level of your plebostatic axis for you to get an accurate value, and all the pressures are given in reference to your right atrium. Zeroing of the pressure transducer. What do you need to zero a pressure transducer? One thing is any pressure that is represented in your pressure transducing systems is in reference to your atmospheric pressure. Am I audible? Everything is clear? Somebody, yeah, okay, right. Somebody just raised their hand so that I'm just asking this whether I'm audible properly or not. Okay. Okay, right. I'll go ahead. So zeroing of transducer is essentially you are telling the transducer what the atmospheric pressure is, so that any pressure that is given to you on the monitor on the screen is the pressure above the atmospheric pressure. So how do you do that? So you have the stopcock, and you need to close the patient end first and open the transducer to the atmosphere, and you need to press the 0 button on the monitor. Thereby the monitor understands the atmospheric pressure, and thereon and before doing zeroing of any pressure transducer, you need to position the pressure transducer at phlebostatic plane. First, position the transducer at phlebostatic plane, then close the patient's end, open the transducer to the atmosphere, and zero it in the monitor. So this gives the monitor atmospheric pressure value or a zero value, above which all your readings will be given. Now I'm going into something called resonance and damping. See, any fluid-filled tube will have this properties of resonance and damping. Resonance is a property where when a waveform is transmitted through the fluid-filled tube, the ability to reverberate or keep resonating is called resonance. Damping is the ability of the tubing system to absorb the waveform. So when you connect any pressure, any catheter to a transducer and to monitor, it intrinsically has some resonance and damping properties, which are standardized. But there are various factors that can affect this damping resonance, which can give you erroneous values. So it is very important for you all to understand what is under dampening, what is over dampening, and how to deal with it. So what is under dampening? See, under dampening is a phenomenon where your waveform gets excessively reverberated in the system. So what does this cause? This causes overestimation of your systolic blood pressure, where your systolic peak will be higher than the normal value. So actually it is supposed to be here on the waveform, but the systolic peak is falsely high, and the diastolic trough is falsely low. So it overestimates the systolic pressure and underestimates the diastolic pressure, but the mean arterial pressure remains unchanged. When does this usually happen? Whenever the tubing systems are too long, or when there is increase in systemic vascular resistance, this under dampening can happen. What is over dampening? Over damping is a condition where your pressure transmitting system or tubing system absorbs a lot of pressure by itself and less is transmitted to the transducer. In such conditions, what we see is the systolic pressure is underestimated. Your systolic peak is low and your diastolic pressure is overestimated, and diastolic trough is high, and your pulse pressure becomes narrow and narrow. And as I told you, in under dampening, the mean arterial pressure remains unchanged. So what can cause over dampening of the system? Any air bubbles in the system, any blood clots or fibrin, or any catheter kings, and even if your flush bag is empty or your pressure bag is empty, this all can cause over dampening of the system. So how can you determine, how can you recognize under dampening or over damping in your system? So this test, dynamic response testing or square wave testing, is one test. It is also called fast flush test, where you can recognize under dampening or over damping of your pressure transducing system. So how to do that? So when to do that first? So every time you connect any pressure transducing system, we need to perform a fast flush test. And if the patient's clinical condition is not matching to the numbers on the monitor, you need to do a fast flush test. Or your arterial waveform appears to be underdamped or overdamped, you need to do it. And before implementation of any important procedures, you need to do a square wave test at least once in 8 to 12 hours, especially during your shift changes. It is very essential for you when you come out of the shift to just do a square wave test and see whether your arterial waveform is well represented, is correctly damped or not. So how to perform this? So it's a very simple bedside test to perform. Just open the flush valve. See if it is a pull tail or if it is squeeze, based on the type of transducer you are using. Just open the flush valve. What happens is when you open the flush valve, you expose the entire pressure transducing system to an acute rise in pressure and close it immediately within 1 to 2 seconds. So once you do that, the pressures that have acutely raised have to return to the baseline. And in a normally resonating tubing system and a normally damped tubing system, The return to baseline occurs with 1 to 2 oscillations. I would be showing this in my next slide. See, in the mid one, the middle red waveform is a normal waveform where when you do the fast flush test, your pressures have acutely raised, and when you just stop it, they come back to the baseline within 1 to 2 oscillations. If the waveform comes back to the baseline value within 1 to 2 oscillations, it is normal. If there are more oscillations, more than 2 oscillations, it is underdamped arterial pressure. And if there are no oscillations at all, it is overdamped. It is an overdamped arterial waveform. So what you do when you have an overdamping system, it is always better to flush the system once, just to check whether there are any kinks, whether there are any air bubbles, whether there are clots in the tubing system, and correct them accordingly. So in this slide, I'm going to discuss briefly about what actually we are looking when we see at the arterial waveform. So any arterial waveform has an anacrotic limb, the upswing, the dicrotic limb, or the downswing. So the anacrotic limb or the upswing is mainly due to cardiac contractility and left ventricular ejection. So when your aortic valve opens and your left ventricle contraction pumps the blood into the aorta, a pressure waveform is created which transmits through the entire arterial tree. This will cause a spike in pressure leading to anacrotic limb, and the highest peak of this anacrotic limb is your systolic pressure. And the dicrotic limb is where your pressure starts falling in the aorta, and as you can notice, there is a dicrotic notch here. The dicrotic notch is a point where your aortic valves closes, followed by left ventricle diastole. So your dicrotic limb is mainly during the diastole, and anacrotic limb is during the ventricular ejection. The area under the waveform, the area under the entire arterial waveform can give you information about the stroke volume. So if you can determine the area under the arterial waveform, you can determine the amount of volume pumped by left ventricle in one beat. So the systolic pressure depends upon cardiac contractility and stroke volume. The diastolic pressure is mainly determined by the systemic vascular resistance. What is systemic vascular resistance? So systemic vascular resistance is mainly determined by the tone of your arteries and arterioles, how far they are contracted. So the systemic vascular resistance actually determines your diastolic pressure. What is mean arterial pressure? Mean arterial pressure is average pressure that is maintained throughout the cardiac cycle, and it is more closer to diastolic pressure than the systolic pressure. Why is mean arterial pressure important? See, the mean arterial pressure is the main parameter which determines the tissue perfusion. So that is the reason when we are resuscitating a patient, we target, or when we are doing giving a vasopressor therapy, we target mean arterial pressures rather than systolic or just systolic or diastolic pressures. What is pulse pressure? The difference between systolic and diastolic pressure is called as pulse pressure. And next couple of slides, I would be discussing briefly about the blood pressure, how it is maintained, and what factors it depends on, and a brief slide about shock and hypotension, what will be the causes. And one more thing is the indications of invasive blood pressure monitoring. So when do you do invasive blood pressure monitoring? Is when you need a real-time blood pressure monitoring, like when the patient is in shock, he's on vasopressor therapy, when he's critically ill, where you need a real-time blood pressure monitoring, you need to go for invasive blood pressure monitoring. And conditions where we need repeated arterial blood samplings, like any patient who is in severe acidosis, any patient who is in ARDS, pneumonia, where we need to check blood gases multiple times. It would be convenient to go for an arterial line for repeated samplings. And when there is any planned pharmacological or mechanical cardiovascular manipulations, such as vasopressor therapies or IABP, there you need to have an invasive arterial blood pressure monitoring. And obviously, when we are not able to get when we're not able to do proper non-invasive blood pressure readings because of various factors, you need to go for invasive. And one more advantage of having an invasive pressure monitoring system is you can calculate the volume responsiveness and especially by pulse pressure variations. See, so in this slide, I'm going to discuss about blood pressure and what it depends on. See, the mean arterial pressure or the blood pressure itself is dependent on mainly on two factors. One is your cardiac output and the peripheral resistance. And again, your cardiac output depends on your heart rate and stroke volume. So whenever a patient has a coronary artery disease, myocardial infarction, LV dysfunction, his overall cardiac output goes down, and that will affect the patient's blood pressure. The second most important factor that determines the blood pressure is your peripheral vascular resistance. As I told you, peripheral vascular resistance mainly depends on your vascular anatomy or the tone of your arterioles, which is mainly controlled by neurohormonal systems like your sympathetic system and your circulating catecholamines. These are the factors that determine the peripheral vascular resistance. These neurofemoral factors, especially sympathetic tone and arterial contraction, is mainly affected by multiple factors, such as in sepsis, where due to release of a lot of inflammatory mediators, there will be vasodilatation and reduction in peripheral vascular resistance that can cause your hypotension and shock. This is just a slide briefly telling you about types of shock. So whenever a patient is in hypotension, these are broadly four categories of why a patient can develop shock. One is your hypovolemic shock. As the name is obvious, the patient's total blood volume is low. It may be because of blood loss or dehydration or in third spacing. All this can cause a reduction in blood volume. The reduction in blood volume can reduce the blood venous return that is coming into the heart, and thereby it reduces the cardiac output and patient goes into shock. This is the hypovolemic shock. The second one is your cardiogenic shock. As I already told you, the blood pressure of any patient depends upon cardiac output and systemic vascular resistance. So when any person has a myocardial infarction, he has LV dysfunction, heart failure, the patient can go into hypotension, and it is called as a cardiogenic shock. Coming to the obstructive shock, here the cardiac contractility is okay, but the ability to heart to expand or relax is impeded by external obstruction. Like patient may be having pneumothorax, he may be having pericardial tamponade or constrictive pericarditis, where the expansion of heart itself is hindered. When heart is not able to relax, then what happens is that the heart cannot receive the venous return. When it is not able to receive the venous return, it can't pump the blood forward into the aorta. This results in shock, and this type of shock is called as obstructive shock. What is distributive shock? Distributive shock is due to reduction in peripheral vascular resistance. As I told you, peripheral vascular resistance is one of the main factors that affect your venous arterial pressure or blood pressure. What happens in distributive shock, especially in patients like sepsis or septic shock, due to release of lot of vasodilatory inflammatory mediators, the tone of arteries and arterioles is reduced, and patient goes into vasodilated state, which can cause shock. And in certain conditions like neurological trauma, like spinal trauma, the sympathetic tone is lost. The loss of sympathetic tone also results in dilatation of arterioles and arteries, causing shock, which is called distributive shock. So this is a gross view of type of shock. I wanted you to know this because most of the times in ICUs, you will be dealing with patients who are in shock, hypotension, on vasopressors, and patients who are receiving fluid resuscitation. So if you understand the type of shock, you can understand what is the therapeutic goals that are needed to correct the shock. Then coming to central venous pressure. So CVP pressure, central venous pressure, how do you measure it? So what are the things that you need to measure a central venous pressure? You need a central venous catheter. The central venous catheter can be introduced from internal jugular vein or subclavian vein. So where do you measure the CVP? CVP is measured usually at a junction of SVC and right atrium. Why is it important to measure CVP, or how is CVP clinically relevant? As I told you, the cardiac output of any patient depends on three factors. One is the preload, second is cardiac contractility, and the third one is afterload. The preload is the total amount of venous return or blood that is coming back to heart. That is called as a preload. Cardiac contractility is obviously the muscle contraction of the cardiac walls, the force by which the heart contracts and pumps the blood. Afterload is the peripheral resistance against which the blood is being pumped. So what does the CVP exactly represents? It is an indirect indicator of the preload, or if it represents the total amount of venous blood that is coming back to the heart. So by placing a CVP and making sure that the tip is somewhere around SVC and RA junction, you can get the CVP value, which can guide our therapy. CVP waveform also has distinctive 3 positive deflections and 2 negative deflections. I would just be telling you about what these deflections are. I'm not going to go very deep into abnormal CVP waveforms. So it has 3 positive waveforms or positive deflections. One is the A, C, and V waveform. A is due to atrial contraction. Whenever the right atrium contracts, this A waveform is created. C is due to closure of tricuspid valve. Once the atrium contracts, once the blood flows into the right ventricle, your tricuspid valve closes, and when the right ventricle contracts, the tricuspid valve bulges into the right atrium. This bulging of tricuspid valve into the right atrium creates this C wave. Coming to the V wave, V is due to venous return. When the right atrium relaxes and when the right atrium relaxes, you will get the X descent. So after a right atrial contraction and closure of tricuspid valve, the right atrium starts descending. That will cause a steep fall in blood pressure. That steep fall in blood pressure is the X descent. And once the relaxation starts, the venous return starts coming into the right atrium. This venous return causes the V wave. V wave is representing the venous return to the right atrium. And once the tricuspid valve opens, all the blood is emptied into the right ventricle from right atrium, causing a Y descent. So that is as per the waveform of CVP. And what are the conditions where the CVP is high? So any volume overload states, the CVP is high. Congestive cardiac failure, where the heart is unable to pump the blood it is getting back as a venous return, your CVP is high. In case of right ventricular failure and cardiac CVP is high. And in cardiac tamponade, where there is extrinsic compression of the heart, your CVP goes up. And what are the conditions where CVP is low? It is hypovolemia. But CVP, as a representative of a preload and as a guidance to fluid resuscitation or fluid responsiveness, is not a reliable marker because it is affected by many confounding factors. And the utilization of CVP as a marker to guide our resuscitation has significantly come down in past few years compared to what it used to be maybe 8 or 10 years back. And then I would like to discuss about a few things about pulmonary artery catheter, because some of you would be working in ICUs where you would be using a few pulmonary artery catheters. So pulmonary artery catheter is introduced from the internal jugular vein or jugular veins into the right atrium, and there into the right ventricle and into the pulmonary artery. So why do you use a pulmonary artery catheter? What things can you monitor using a pulmonary artery catheter? So obviously a pulmonary artery catheter can give you pulmonary artery pressures. It can also give you the right ventricular pressures. And the one most important parameter that it can give you is pulmonary artery occlusion pressure. As you can see at the tip of the pulmonary catheter, there's a small balloon with a volume of 1.5 cc. So whenever the pulmonary artery catheter is placed into the pulmonary artery, and if the balloon is inflated, the pressure is called as pulmonary artery occlusion pressure. You need to understand that the pulmonary artery occlusion pressure, when the bulb is inflated, represents the left atrial pressure. It no more represents the pulmonary artery pressure once the balloon is inflated, because of it represents the back pressure from LA, and you can clearly see left atrial pressure waveforms also. So these are the three main things which we monitor using pulmonary artery catheter. And one more important utilization of pulmonary catheter is your cardiac output monitoring. Not all pulmonary catheters have the ability to monitor the cardiac output. They need to have a thermodilution catheter built in, and these catheters can give you an exact and most representative value of cardiac output. And measuring cardiac output by using a pulmonary catheter is considered as a gold standard thing. I would be explaining about this when I go into cardiac output monitoring. And I would also like to talk about the ports of a pulmonary artery catheter. See, as a nursing staff, you need to be very clear about the color coding of the PA catheter ports. Why? Because it is very important. The first is a red color. The red color is the balloon inflation port. As I told you, there is a balloon at the distal part of the pulmonary artery catheter. The 2 cc syringe is attached to this balloon inflation port, and whenever you inject air through this balloon inflation port, your balloon will be distended. And one major thing we should all remember is this balloon should never be kept inflated. Once you inflate it, you measure pulmonary artery occlusion pressure, it should always be deflated immediately. Okay, what happens if you keep it inflated? See, when your pulmonary artery catheter is in the pulmonary arteries, and when you keep the balloon inflated, you are going to stop blood supply to a part of the lung, so it can cause pulmonary infarct in some area. That is the reason why you do not keep the pulmonary artery catheter balloon inflated continuously. You need to inflate it, take a pulmonary artery occlusion pressure reading, and deflate it immediately. And this white color is for right atrial infusion port, where you can infuse any drugs or any medications. The yellow color port is a PA catheter distal port. This opens at the distal part of the pulmonary artery catheter. The blue one is proximal injected port. This is mainly used for measurement of cardiac output, where you inject cold saline. And this is the thermistor port, where you connect this to the pump PA catheter to the monitor to get the value of cardiac output. And it's very interesting to see this waveform. See how we put a PA catheter in the ICU is by waveform guidance. It is not by fluoroscopy guidance or not any radiological guidance. It is mainly through the waveform guidance. You can observe when the PA catheter enters the right atrium, this is the waveform. It is the CVP waveform. When it enters the right ventricle, the waveform changes. The systolic pressure goes up to 20 to 25. Diastolic pressures will still be low. It will be around 0 to 5 millimeters of mercury. This is the right ventricular waveform. Okay, when you push the PA catheter further ahead, it enters the pulmonary artery. Then when the pulmonary artery catheter enters the pulmonary artery, you can see that the diastolic pressure immediately raises from 0 to 5 to around 10 to 15 millimeters of mercury. Okay, this indicates that the pulmonary artery catheter has entered the pulmonary artery. And when you when you inflate the balloon, when you inflate the balloon, then you would be seeing a left atrial pressure waveform. As I told you, when you inflate the balloon, the pressure waveform that you see on the monitor represents the left atrium rather than the right side of the heart. That gives you pulmonary artery wedge pressure or pulmonary artery occlusion pressure. So what are the in the uses, or how do you read pulmonary artery wedge pressure? When will it increase? Increased pulmonary artery wedge pressure, the normal value is around 12 to 16 millimeters of mercury, and an increase in pulmonary artery wedge pressure occurs when there's a left heart failure or left ventricular failure, or in other words, heart failure. When there's volume overload and there's a cardiac tamponade or constrictive pericarditis. The main clinical utility of pulmonary artery wedge pressure is to differentiate between your cardiogenic and non-cardiogenic pulmonary edema. When your lungs are wet, patient's oxygenation is low, and to differentiate between what is the cause, whether the heart failure is a cause or the pulmonary infections or pulmonary ARDS is per se the cause. Your pulmonary artery wedge pressure can clearly differentiate. And pulmonary artery pressures, these are the pressures in the pulmonary artery before you inflate the balloon. Before you inflate the balloon, it is pulmonary artery pressure. Once you inflate the balloon, it is called pulmonary artery wedge pressure. So pulmonary artery pressures are usually elevated in your pulmonary diseases, cor pulmonale, and some other conditions like even in left ventricular failures and mitral valve disease as well, the pulmonary artery pressures are elevated. And as I told you, one more, the most gold standard system for measuring cardiac output is your pulmonary artery catheter based cardiac output measurement. So I would then I would like to discuss a few slides, couple of slides about cardiac output monitoring. I will not go too deep into the cardiac output monitoring. I would just outline the different types of cardiac output monitoring, and because some of you would be doing that in your ICUs, and what are the intricacies of it. So cardiac output monitors or monitoring, why should we do it? So especially patients who are in shock, who are in severe shock, the cardiac output monitoring can differentiate between the types of shock, whether it is cardiogenic, is it septic, is it a vasodilatory, or what is the cause of shock, and it can guide us the therapies that we give for shock. That means whether the patient needs vasopressors, do the patient needs more fluids, or do the patient need inodrops to increase the cardiac contractility. These all things can be known by using a good cardiac output monitoring. So while going into types of cardiac output monitoring, broadly can be divided into three types. One is invasive, the second is minimally invasive, third is non-invasive. Invasive and the gold standard of cardiac output monitoring is your pulmonary artery catheter. So how do you do it? What is the mechanism behind it? Why do you inject cold saline while measuring cardiac output? See, whenever you add any cold fluid to a hot fluid, you add some cold water to a bucket of hot water, the temperature comes down. In the same way, when you add ice cold saline to the blood, the temperature of the blood also comes down slightly. But how much does it come down? Depends on the rate of blood flow. And the blood flow depends on your cardiac output. So there is a catch. So the temperature change is determined by cardiac output. So by measuring the temperature change after giving a cold saline, you can tell exactly how much the cardiac output is. So in the invasive type, where you put a pulmonary artery catheter, the distal part of the pulmonary artery catheter has a temperature sensor, and you have a port proximally where you can inject cold saline into right atrium. So what you do essentially is you inject cold saline into right atrium and you measure the temperature in pulmonary artery. And the rest of the thing, you don't need to do anything. The monitor does all the calculation. Luckily for us, we are all poor in mathematics. So the monitor does all the calculation and gives you the cardiac output, stroke volume, and a lot more other parameters, interesting parameters, which help in guiding the therapy. I'll show you all those parameters, some of the parameters. That is pulmonary thermodilation. The procedure is called pulmonary thermodilation, where you give ice cold saline, measure the temperature change, and you get the cardiac output. Next one is the minimally invasive cardiac output monitoring. So this depends on two things. One, if you remember on the beginning of my class, when I was explaining the arterial waveform, I told you that an area below the arterial waveform gives the information about stroke volume. Actually, so below the arterial waveform, the area under the arterial waveform is stroke volume. So what is heart cardiac output? It is nothing but stroke volume into heart rate. So if you know what is the volume that is pumped in one stroke, you can know what is the volume pumped in 70 beats or 100 beats. So if you know the stroke volume, you can know the cardiac output. So what does the monitor do? This minimally invasive technique is called pulse contour analysis. You might have, some of you might have used this flow track or this Vigilio cardiac output monitor, where you have a special type of transducer which you connect to arterial cannula of the patient, and you get the arterial waveform trace, and the monitor measures the area under the waveform, and it gives you the stroke volume, cardiac output. It's as simple as that. And there is slightly more advanced pulse contour analysis, where you do something called as a transpulmonary thermodilution. If you remember, I explained you what is thermodilution in PA catheter cardiac output monitoring, the gold standard one. Here, what we do is we give in transpulmonary thermodilution. In order for us to get an accurate cardiac output, we need two things. One, you need a femoral catheter, femoral artery catheter that has a temperature sensor, and you need to have a central venous catheter or CVP line. You give ice cold saline through CVP line, and the ice cold saline enters the heart, goes to lungs, comes back to the heart, and goes to the systemic circulation and reaches the femoral arterial line, where obviously your temperature sensor is waiting to pick up the temperature change. As I already explained to you, based on the temperature change of blood after giving ice cold saline, your monitors or your microprocessors can calculate cardiac output as accurate as anything. So what do you need? You need a CVP line, you need a femoral arterial catheter with a temperature sensor that is given with that particular cardiac output monitoring kit, and you need to inject ice cold saline, and you need to and the rest of the thing the monitor does. Okay, it gives you a lot of indicators like your cardiac index, cardiac output, stroke volume variation, and a lot of intrathoracic parameters. So this is briefly about thermodilution. And we also have non-invasive methods of cardiac output monitoring, like your bioimpedance-based cardiac output monitoring. I think this is by far the most simplest hemodynamic monitoring that we'll ever do. Just attach a couple of leads to the patient, and one of the lead will generate a small electrical impulse. The other lead senses the electrical impulse, and it senses the change in the electrical impulse when it passes through your thorax, through all the blood volume in your thorax, through your heart. The electrical signal passes and it gets altered and picks up by the other sensor. So based on the change in that electrical impulse or bioimpedance, the monitor can give you how much of blood is flowing through your thorax and how much of blood is flowing through your heart, and it can give you the exact approximate values of stroke volume, cardiac output, and other hemodynamic monitor parameters. So this is briefly about cardiac output monitoring. So I have discussed about the basics of pressure transducing and basics of pressure measuring in ICUs. I have discussed about arterial waveform, and I discussed briefly about blood pressure and shock, and a few slides about CVP and CVP monitoring. And I also discussed about PA catheter, its positioning of PA catheter, and what are the indicators in the PA catheter that we utilize clinically. And I discussed briefly about cardiac output monitoring, types of cardiac output monitoring, and the invasive, non-invasive, and minimal invasive methods. So with this, I conclude my talk, and I would be going into the MCQs. Here we have a few MCQs. And before going into MCQs, I would like to ask if there are any questions or doubts from the students here.
Any specific questions from the audience? A lot of people have raised their hand while the talk is going on. Anyone wants to ask any specific question?
Any questions? You can type in the chat box. We'll wait for a minute and we'll go into the MCQs. I have 5 to 6 MCQs here.
There are no questions. Either you're, all the people have understood how actually you describe the things, or they don't want to ask questions. Any questions on Facebook Live? Anything around? I mean, the ICC person who's coordinating can let us know on that also.
Go to MCQs.
So okay, we'll go to the MCQs.
We'll go to MCQs. I have 6 MCQs here. I'll show that. Any answers?
They can answer in the chat.
People, you can answer in the chat box. So and we can have a brief discussion and move on. So the first MCQ. So for arterial pressure monitoring system, the pressure bag, how much should be the inflated pressure? Any answers from the audience? That's correct. Somebody already answered it. Any more answers? Yeah. Yes, it is 300 millimeters of mercury. The answer is B. So make sure always your pressure bag pressure is maintained at 300 mm mercury. Why? Because it should always be above your systolic blood pressure, so as to avoid the backflow of blood. And this continuous flush system also flushes the system with around 3 ml per hour. A small amount of flush will be keeping on going into the system so that it is maintained well. I'll go to the next question. When zeroing a pressure transducer, the stopcock should be adjusted to phlebostatic axis. The phlebostatic axis represents which part? What does it represent, the phlebostatic axis? Yes, the answers are pouring in. A couple of answers. One is wrong. I'm sorry to say. It is not angle of Lewis, but it is right atrium. See, always your phlebostatic axis should be is actually represents the right atrium. The fourth intercostal space with axillary line is your landmark. Remember that. And your stopcock of your transducer should always be on par to that of phlebostatic axis. I'll go to the next MCQ. So what does the A wave mean in CVP waveform? Any idea? Any answers? I explained to you the CVP waveforms and the positive and negative deflections in CVP waveform. So yes. Okay, I'll tell you the answer. It is the atrial kick just found after the P wave. So once your P wave is done, your right atria and left atria will contract and pump the blood in. Your right atrium will contract mainly and pump the blood into right ventricle. So that is the waveform that is represented in CVP in the shape of A. What is a normal pulmonary capillary wedge pressure? Any idea? Anyone? I mentioned it.
I think there are a couple of questions.
I think there are a couple of questions in the chat box, and we would be answering that once this MCQs are done. So the normal pulmonary capillary wedge pressure is A. That's correct. That's 12 to 16 millimeters of mercury, and pulmonary capillary wedge pressure of more than 18 millimeters of mercury usually indicates that there is some cardiac failure or LV dysfunction leading to cardiogenic pulmonary edema. It's A. It's A. Answer is 12 to 16 millimeters of mercury. Carefully observe the waveform here and tell me what you see. The above picture is fast flush test, and the below one is the corresponding waveform. Yes, yes, it is under dampening of the system. See, when the system is under damped, you will have a lot of oscillations in your arterial waveform. And when you do a fast flush test, there will be more than 2 arterial waveforms. And so this is an underdamped system. What does this fast flush test indicate? Which of the following is true? Sorry, which of the following is true regarding this overdamped system? This is overdamped system. So what is true regarding this? Yes, true. All of the above options are true. What happens is your systolic pressure is underestimated, your diastolic pressure is overestimated, your mean arterial pressure is unchanged, and this overdamping can be caused by air bubbles in the system, it can be caused by blood clots, it can be caused by kinking. So whenever you see a overdamped arterial waveform, confirm it with a fast flush test and make sure you flush your pressure monitoring tubing systems. Make sure they're free of any blood clots, they're free of any kinks, so that you can get an accurate reading of your blood pressure. And there are a couple of doubts that have been raised. Can we do zeroing in sitting position? Yes, we can do zeroing in sitting position, but make sure the transducer is in phlebostatic axis. Your transducer should be at your phlebostatic axis before you do the zeroing. That is more important than anything else. What should be length of tubing is for hemodynamic monitor? What do you mean by non-compliant tubing system? See, the pressure monitoring tubes that you use to connect the catheter to the transducer, they are specifically made for pressure monitoring. Their walls are slightly stiffer than your normal IV cannulas or fluid infusion sets, and they do not absorb the waveform as much as a normal IV lines can do. So be careful to connect the correct pressure monitoring tubing system to the cannulas so that there is not too much of damping. So and the pressure that is seen is more representative and more accurate. Any other questions? Okay, shall I?
Yeah, I think it's been an excellent presentation by Dr. Shashi. Covering all the basic aspects and answering the couple of doubts that have been posted around. If any further doubts, if there are no doubts, then probably we can end the session. I don't think there are any doubts. Can we end? Yeah, we can. I think we can end the
So we'll end the session here, and thank you ICCM for giving us this opportunity, and thank you very much.